Good evening, one and all. Welcome you for the post-tea session of the day. This is the last symposium, and to start with, I would like to invite Professor Sridhar sir from Chennai and Dr. Syed Sultan sir from Madurai for chairing the session. So I would like to invite the chairperson to start the proceedings for the next three sessions.
Name is wrong. Good evening to all. Thank the organizers for this excellent organization and kind invitation. So, regarding inpatient hyperglycemia management, it's of course, the whole thing is slowly undergoing a change. About 20 years back, there was the famous surgical study of Vandenberg, where they indicated that very tight control of sugar, keeping the glucose around below 110, is very advantageous for quick healing and improves mortality and morbidity. So there was a lot of interest, but the same Vandenberg group, they conducted a study in the medical ICU and did not replicate their own epoch-making findings few years later. So subsequently, we are enthusiastic about control of sugar, but nevertheless not at levels like 160 to 180 milligrams would be sufficient. So tell us more about inpatient management is none other than Dr. S. Ramkumar, MBBS, MD, DM, All India Institute, and DNB Endocrinology. Is clinical fellowship in diabetes in New Zealand and fellow of European Society of Sexual Medicine. He is assistant professor of endocrinology at Madras Medical College and also attached to Apollo Main Hospitals and Dr. Ram's Clinic. And he's awarded the A.V. Gandhi Award for Excellence in Endocrinology in 2014 and ISPAD Alan Rash Clinical Fellowship in 2014. He has numerous publications. And without further ado, it's over to Dr. Ramkumar.
Good afternoon, sir. Okay. So I sincerely thank Dr. Kumaravil sir for giving this opportunity to talk on Trendo. Actually, this is my first talk on Trendo in a physical form. This topic, management of hyperglycemia in a hospitalized adult, this was decided a month back. Fortunately, 2 weeks back, this was the publication from our endocrine society. This is the management of hyperglycemia in hospitalized adult in a non-critical care setting. So I just share what the society wants us to know in the next 15 minutes. This is actually an update on the 2012 guideline. So to me, this guideline looks like more or less a generalized statement, unlike other protocols where they are giving exactly how much to give, how much units per kg to give, or which at what level should we intervene, how much to step up. This is more or less a generalized statement. The reason is obvious because every patient has to be individualized. Unlike a DKA where there is a fixed protocol, here there are a lot of factors which could interfere. So whenever a patient gets admitted in the hospital, there are many reasons why the sugar can go high, from stress response, the administration of any steroids, octreotide, or any continuous enteral nutrition or a parenteral nutrition, and also a decreased level of activity. All these can contribute to high blood sugar, which can subsequently predispose to a lot of changes at the cellular level, oxidant damage, which can predispose to infections, and increase the morbidity as well as the mortality. As I was telling, in the early 2000, the major landmark trial published actually showed that if you control the blood sugar in an intensive way, maintaining between 80 to 110, it actually improves the outcome. A subsequent study also showed an intensive glycemic control improves actually the outcome. But subsequent studies that nice sugar have changed the way the patients with diabetes are managed at hospital. So if you actually look at the way you want to treat a patient, see whether the patient is critically ill, whether the patient is admitted in the intensive care unit or it's just admitted in a routine ward for maybe for an infection, maybe for a surgery, etc. So these are the two important landmark trials. One is the NICE sugar and the glucocarb. These two trials have shown that if you try to control the sugar intensively, the mortality is actually much more. The first study published in NEJM in 2009 showed that the intensive glucose control increased the mortality. A blood glucose target of less than 180 resulted in a lower mortality than did a target of 80 to 108. The second study, the gluco-CABG, intensive insulin therapy to target sugar between 100 and 140 in the ICU did not significantly reduce the perioperative complications compared with a target glucose of 140 to 180. So these were the target glucose concentrations in the critically ill and non-critically ill. After the NICE sugar guidelines, the ADA and AAC has published a consensus statement that the sugars should be maintained between 140 to 180 for majority of critically ill patients. If you could avoid hypoglycemia for selected patients, a target of 110 to 140 is acceptable. The Society of Critical Care Medicine recommends a value between 150 to 180, and for non-critically ill, the initial recommendation by both AD and AAC was a pre-meal of 140 and a random of 180. The latest, the ADA 2022 guidelines recommend whether the patient is critically ill or not critically ill, a value between 140 to 180. And this is by the Joint British Diabetic Society, a recommendation of 108 to 180. So if you actually look at the protocols that are available in the literature, most of these protocols on continuous insulin infusion are all in the early 2000s. So most of these protocols are trying to control the sugar much stricter. This is one protocol which is published in 2005, the AL insulin infusion protocol. The aim is to control the blood sugar somewhere between 80 to 110. This is another protocol which was published in the endocrine clinics. So if you actually look at the protocol, between 110 to 180, they are not recommending any change. So they're trying to maintain the blood sugar somewhere between 110 to 180. If you look at both these protocols, actually what they look at is two factors. One is absolute sugar level and the rate of change in blood sugar over the last 1 hour. Here they have taken a blood sugar, the decline of 30 milligrams or an increase of 30 milligrams is taken to make a decision in the insulin adjustments. So for these type of adjustments, the staff nurse who is looking after the patient has to be very vigilant and to adjust the blood sugar. So this is possible only in the 1:1 nursing care setup. This is the another protocol, that is variable rate intravenous insulin infusion. Here, the absolute value is taken into consideration, but not the rate of change. So if the sugar goes to another level, say for example from 210 to 180, then the rate of infusion changes from 2 to 1. So here we have a reduced rate, standard rate, and increased rate. This is a publication by the Diabetes UK and also the position statement of the Joint Diabetes British Society. I think this is the only thing which I could find. There are other variable rate intravenous insulin infusion. This is by standard consensus statement. Here they have 3 scales. Suppose if you find when decreasing the insulin infusion, the sugar starts going high, then you can go to the higher scale. Or you can even give a customized scale handwritten to the staff nurse to decide on the insulin rates. This is a protocol which we follow in our critical care unit. So if you actually look at it, you can see the rates are much, much higher than the previous insulin the variable rate insulin infusion. The rates up to 13 units per hour. And one thing which you can see also here is the CBG monitoring once in 2 hours. Personally, if any of my patients are getting admitted in critical care, I always ask them to monitor it hourly. If you monitor hourly, the chance of hypoglycemia is actually very, very less. So it's always better to monitor the blood sugars hourly. So what ADA says is ADA is not giving any protocol. It just recommends that any validated protocol or a computerized protocol has to be followed. It depends on the hospital. And use of a sliding scale insulin regimen is strongly discouraged. Most of us have already been using a sliding scale regimen. At the maximum, we can use it for a period of 24 hours. Beyond 24 hours, I think you know how the patient reacts and how the patient's diet intake, everything, and we can go to a scheduled insulin regimen. So once the patient has been on intravenous insulin infusion and he's stable, the blood sugars are remaining stable, there is no acidosis, the normal anion gap, the hemodynamic stability is there, he's taking nutrition, meals at regular intervals, and the infusion rates are stable, we can change to a subcutaneous insulin. So these are all about the patients who are critically ill. Now coming to the JCM guidelines on patients who are not critically ill, I'll just go through the recommendation one by one. The first recommendation is on continuous glucose monitoring system. So this guideline recommends the use of continuous glucose monitoring system in patients who are at high risk of hypoglycemia, and provided you have the resources to monitor it. If the patient CGM is not available, or if the resources are not available, or the patient is not at high risk of hypoglycemia, point of care blood glucose testing is an alternative. So who are all the patients at high risk of hypoglycemia? The elderly, patients with chronic liver disease, heart failure, renal failure, they have a pancreatic problem, they are have an active malignancy, they have a previous hypoglycemia, etc. So these continuous glucose monitoring may not be applicable in situations like extensive skin infections, shock, those who are receiving inotropic support, and certain drugs. So the next recommendation is on insulin pump. So if the same thing here again, if the patient has already on insulin pump and you have a staff nurse who is trained in insulin pump, then it's better to continue with the insulin pump therapy rather than changing to a subcutaneous basal bolus regimen. But if a patient has an impaired level of consciousness, inability to adjust the pump settings, and critical illness, decay, or hyperosmolar state, then they are not the candidates for insulin pump. So the next recommendation is on glucocorticoids. If the patient is on receiving glucocorticoids, recommendation is to give a NPH or a basal bolus regimen. So when we give a short-acting prednisolone in the early morning time, the prednisolone reaches a peak level at 4 to 6 hours. The NPH also peaks at the same time, 4 to 6 hours, and that is the reason it is always better. It's always better to give both NPH and prednisolone concomitantly. That is the latest ADA 2022 guidelines. So if a patient is on long-acting steroids like dexamethasone, or the patient is getting multiple doses of steroids, then we can go for a long-acting insulin basal bolus regimen. So these are the different ways we can manage diabetes in a patient on steroid. If the patient is on multiple doses of insulin, unlike the routine situation where you have a high or an equal 50-50 of basal and bolus, here more of a prandial is required, especially after the lunchtime, and the basal requirement is less. If the patient is not a diabetic and he's become hyperglycemic after initiation of steroids in the morning, a single dose of isofene insulin in the morning. If you are giving isofene insulin 2 times, then you can give 2/3 of isofene in the morning and 1/3 in the night. And this is another interesting way of managing diabetes. If the patient is already on basal bolus regimen and started on a steroid, then adding an NPH to the usual basal bolus regimen. And regarding diabetes education, it's very clear that every patient needs to be given an inpatient diabetes education, but it is obvious that we cannot give the same type of education for a hospitalized patient, so many of times the staff nurse may not be having sufficient time. So at least prioritize for those people who are started newly on insulin, who are admitted for the first time with diabetes, they have a type 1 diabetes, and who have a diabetes-related complications. And next recommendation is on preoperative glycemic control. So what should be the target HbA1c and the target blood sugar levels? The recommendation is to have a HbA1c less than 8% and blood sugar between 100 to 180. If you cannot achieve a HbA1c less than 8%, then at least have a preoperative blood sugar between 100 to 180, which should be at least 1 to 4 hours before the surgery. And this is one of the difficult areas in the inpatient management, patient on enteral nutrition. So either a NPH or a basal bolus type of regimen is recommended. So this is one flow chart. If you actually look at it, if there is a facility for continuous intravenous insulin infusion, this is the best. Or if they have a facility for automated closed loop insulin delivery, it is the best. But if these facilities are not available, the patient is in the general ward, then the patient is receiving a parenteral nutrition, then the recommendation is to add insulin in the parenteral fluid itself. Or if the patient is on enteral feeds, then you can follow a basal bolus regimen. A basal, here they actually mentioned NPH thrice a day, detimir twice, and glargine once a day, and supplemental insulin start short acting every 4 to 6 hours. If the recommendation is on oral hypoglycemic drugs, so in most patients, we suggest that scheduled insulin therapy to be used instead of non-insulin therapies for glycemic management. So that is in most patients, but what we generally do, most of us would be giving patients on metformin, sulfonylureas, and gliptins. But these are all not studied well, but recently there are a lot of studies on DPP-4 inhibitors as well as GLP-1 analogs. DPP-4 inhibitors may be appropriate in selected patients, especially those with non-insulin requiring diabetes nearing hospital discharge. And if the patients are very stable prior to discharge, then as a part of a coordinated transition plan. In selected adult patients who have a mild hyperglycemia, DPP-4 inhibitors can be given with the correction insulin, or we can change to a scheduled insulin therapy. Who are those selected patients? If the HbA1c is very less than 7.5, blood sugars are like less than 180 or 200, and the requirement for insulin is very less, like 0.6 units per kg, then we can recommend a DPP-4 inhibitors with a correction insulin. So this was one of the review article on should we give oral hypoglycemic drugs in patients in the in-hospital stay. This was the statement by them that not all patients need to be treated with insulin. In particular, stable patients with good nutritional intake and preserved renal function. Solid evidence indicates that incretin therapy, particularly DPP-4 inhibitors alone or in combination with the basal insulin, is safe. And no prospective studies have determined the efficacy of other, which means metformin and sulfonylureas in the hospital setting. So these are the other non-insulin agents and what are the pros and cons of these agents. Most of the guidelines, you see, even the ADA 2022 do not recommend non-insulin medications because of the two reasons. One is safety and efficacy. Metformin because of lactic acidosis due to anaerobic metabolism in sepsis, hypoxia, impaired metformin clearance or impaired lactic acid clearance. And they are contraindicated in these in situations. Sulfonylureas, the main concern is actually sustained hypoglycemia. If you look at the risk of hypoglycemia with sulfonylurea and basal bolus regimen, actually the risk of hypoglycemia is much more in the basal bolus regimen than with sulfonylurea. And thiazolidinediones, fluid retention, delayed onset of action. SGLT2 inhibitors, now even the authors strongly recommend not to use SGLT2 inhibitors, especially in patients who have a variable diet pattern, risk of ketosis, risk of euglycemic DKA and mycotic infections. But nowadays, at the time of discharge, most of these cardiologists are starting the patients on SGLT2 inhibitors at the time of discharge. DPP-4 inhibitors, as I mentioned earlier, there are even the endocrine society recommends it because it decreases the insulin injections and it is safe and effective in mild to moderate hypoglycemia, hyperglycemia. GLP-1 receptor agonist, there are a lot of studies on GLP-1 receptor agonist, but the main risk factor is the increased prevalence of GI side effects. The next recommendation is on preoperative fluids, generally non-carbohydrate containing NS is recommended, but in one of my recent patients with appendicitis, almost it's kept for nil oral for a long time. So in those conditions, we can add a DNS with a neutralization drip. So on carbohydrate counting, this is rarely we practice carbohydrate counting in an adult type 2 diabetes. We usually follow it in a type 1 in a younger age group. This is it's not necessary to follow carbohydrate counting in non-insulin treated patients. And if the patients are if the adult patient with type 1 diabetes or insulin treated type 2 diabetes, also the carbohydrate counting is not mandatory, either a carbohydrate counting or no carbohydrate counting with a fixed prandial insulin dosing. Regarding correctional insulin, there is a difference between correctional insulin and a sliding scale. So in adults with no diabetes, no prior history of diabetes, the blood sugars are more than 140, we can recommend a correctional insulin. If the patient has a persistent sugar more than 180, then we can go for a scheduled insulin regimen. In a patient with established diabetes, we suggest therapy with either correctional insulin or scheduled insulin therapy as long as the sugar is below 180. But if the sugar is more than 180, it's always better to go for a scheduled insulin therapy. Scheduled insulin therapy means actually a basal bolus regimen. So if the patient has already been treated with insulin, we continue the same insulin regimen in the hospital and try to maintain the blood sugars between 100 to 180. Pre-mixed insulin regimens are not routinely recommended in hospital use, but most of us widely use that in our practice. Especially, this is safe, especially if the patients have a good dietary plan. For example, someone who is admitted for any infections and their appetite is normal, then this can be considered. But ADA recommends against the use of pre-mixed insulin regimens. So most of the sugar orders we give it through the phone. So having a fixed printout like this and giving to the sister might be very useful. When to check the sugar, which insulin to give, how frequent to give, and how much dose of supplemental insulin, correction insulin to give. As I said earlier, the sliding scale is different from correctional insulin. Suppose, for example, if you give recommended 5 of regular insulin and the blood sugar is like 180 to 200, then 5 plus 2. So 7 units of insulin will be given at the lunchtime or the time. So this is in a short, if the patient is having high sugar, nothing by oral, basal insulin. If the patient takes orally, a basal bolus regimen. So this is combining both the critical ill and hyperglycemic, non-critically ill. In severe DKA and hyperosmolar hyperglycemic conditions, we give a fixed dose of insulin, whereas in critically ill patients, we give a variable dose insulin, continuous insulin infusion. And once it is stable, you can change to a basal bolus regimen. If the patient has type 1 diabetes, then we are going to follow the basal bolus regimen. If the patient has a type 2 diabetes and mild hyperglycemia, consider gliptins or a low dose basal insulin. Moderate hyperglycemia, basal insulin with the gliptin plus correction insulin. If the patient has a severe hyperglycemia, basal bolus regimen. Okay. So continuous intravenous insulin infusion remains a choice for hyperglycemic crisis. For non-critically ill patients, insulin is still a choice, preferably a basal bolus regimen. If mild to moderate hyperglycemia, basal insulin with DPP-4 inhibitors, or mild hyperglycemia, DPP-4 inhibitors, then a bolus, then a correctional insulin can be given. Thank you very much.
Thank you, Doctor, for your excellent presentation. As we all know, diabetics, they have increased the risk of hospitalization, and hyperglycemia that is implicated in the increasing the mortality and morbidity, which needs a protocol-based effective treatment. You discussed all aspects in a very clear way. Thank you. And we'll go to the next topic. Steroids, a savior, Satan, or a serpent. Dr. Satish Kumar from Puducherry will give the lecture.
Pointer. Good afternoon, ladies and gentlemen. It's my proud privilege to be part of Trendo 2022, and I would like to thank Dr. Kumaravel, Dr. Manikandan, and the Madurai team for having given me this opportunity. I would go about this topic in the following order. First, deal with the overview of this topic, go on to the functions of the glucocorticoids, the route of administration and the formulations involved, the therapeutic uses, the effects of the steroid excess, and go on to summarize the talk. All steroids have a common cyclopentanophyrhydrophenanthrene structure and are produced predominantly by the adrenal cortex as well as gonads. The adrenal cortex predominantly produces steroids, which can be categorized into three categories, namely the glucocorticoids, mineralocorticoids, and the androgen precursors, which also estrogens. Therapeutically, these corticosteroids can be categorized into based upon their mineralocorticoid and their glucocorticoid property. Glucocorticoid property being classically shown by the anti-inflammatory potency and the mineralocorticoid effect shown by the sodium retaining potency. And hydrocortisone is the classic prototype with the standard with the anti-inflammatory potency of 1 and a mineralocorticoid potency of 1, and based upon which prednisolone has anti-inflammatory potency of 4 and mineralocorticoid potency of 0.8. Here we'll have to see that dexamethasone and betamethasone are purely glucocorticoids with no mineralocorticoid activity, and they have a long duration of action. And additionally, we have to remember that the prednisolone, whatever we use, has an intermediate duration of action. When it comes to functions, the predominant metabolic function is to degrade the muscle proteins and increase the nitrogen excretion and increase the glucose levels and the hepatic glycogen synthesis, and to increase the fat mobilization and to redistribute fat. As regards the immune function, it increases the anti-inflammatory cytokine production while decreasing the pro-inflammatory cytokines, and also decreases all inflammation related cytokine downstream pathways involving prostaglandins, leukotrienes, bradykinin, and serotonin, and decreases the blood counts of eosinophils, basophils, and lymphocyte counts, while it increases the neutrophil, platelet, and RBC count, and also impairs the cell-mediated immunity. The hemodynamic parameters as such, it helps to maintain the vascular integrity and reactivity and responsiveness to corticosteroids pressure effects, and maintains the fluid volume, and it also serves to modulate the perception and emotion and decreases CRH and ACTH release. As regards administration of steroids, the route of administration would depend on various factors. Primarily, that depends upon the disorder to be treated, the formulation which is going to be used, oral, inhalation, topical, or parenteral, and the route will depend upon the drug to be used and the disorder treated. Parenteral route is used in emergencies and oral drug intolerance, and oral is commonly favored for chronic diseases, and it's always preferred for non-systemic therapy whenever possible. Coming to the indications, the prime endocrine indications would include the primary and the secondary adrenocortical insufficiencies, congenital adrenal hyperplasia, hypercalcemia associated with cancer, subacute thyroiditis, and active thyroid ophthalmopathy. While for rheumatic diseases, it's used as adjunctive therapy for short-term administration in psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis, non-specific tenosynovitis, acute gouty arthritis, and synovitis of osteoarthritis. Dermatological conditions, steroids have a wide gamut of use, and its prime use is in pemphigus, all the bullous disorders, predominantly the bullous dermatitis herpetiformis, then Steven-Johnson syndrome, exfoliative dermatitis, severe psoriasis, and eczema. And also in allergic states where control is not achieved by conventional treatment, it's used in seasonal allergic rhinitis, bronchial asthma, contact or atopic dermatitis, and drug hypersensitivity reactions. It's also a savior for various ophthalmological conditions like allergic corneal marginal ulcers, herpes zoster ophthalmicus, diffuse posterior uveitis and choroiditis, sympathetic ophthalmia, allergic conjunctivitis, optic neuritis. It also finds a use significantly in systemic sarcoidosis, in Loeffler's syndrome not managed by any other means, and in disseminated pulmonary tuberculosis concurrently with ATT drugs, and aspiration pneumonitis. And hematologically, it finds use in ITP in adults, in autoimmune hemolytic anemias, and in multiple myeloma, and in collagen vascular diseases when there is exacerbation or as a maintenance treatment in selected conditions of SLE, systemic dermatomyositis, or giant cell arteritis. And neoplastic diseases for palliative management of leukemias and lymphomas, and for acute leukemia in childhood. And for gastrointestinal disease to tide over critical period of disease in ulcerative colitis and regional enteritis. And for miscellaneous conditions like acute exacerbations of multiple sclerosis, and to induce diuresis and remission of proteinuria and nephrotic syndrome, and in tubercular meningitis with subarachnoid block or impending block when used concurrently with appropriate ATT. So now we have found that it has been a savior in multiple etiologies, multiple conditions. We will see what are the side effects due to these steroids. First, we will deal with the metabolic endocrine conditions and the other side effects. The classic one is the iatrogenic or exogenous Cushing syndrome, which can result due to chronic steroid use and can lead on to steroid-induced diabetes and secondary adrenal insufficiency, growth retardation. It can lead to, especially in children, when used chronically, it leads to growth retardation. It's found to delay growth spurt and puberty initiation and hypogonadism and delayed puberty, and also leads to fat accumulation in disproportion, namely accumulation of adipose tissue in facial, dorsocervical, and abdominal regions with loss of subcutaneous fat thickness in the limbs. So, one commonly seen feature is skin atrophy, and with increased skin fragility, and you can see purpura here. It's really ecchymosis what is seen with a cigarette paper like consistency, and we have striae. Classically, a broad livid striae is a classic of Cushing's, and we have acne presenting due to glucocorticoids, and also hirsutism in this corticosteroid excess patients. Other feature which is classical of the glucocorticoids is the myopathy. Corticosteroids have been associated with proximal muscle weakness and atrophy, which has been developing over weeks and months. And higher doses has been lead to a more rapid onset. Classically, myalgia and muscle tenderness is not typically seen, and there is a severe catabolic effect on these muscles, and the symptoms typically improve and resolve at 3 to 4 weeks after discontinuation of these steroids. As coming to neuropsychiatric side effects, it predominantly affects the mood with mood lability, depression, mania, and bipolar symptoms predominating. It also can lead to anxiety, psychosis, and suicidal ideations. And Cognitive effects are more common than the mood effects due to these steroids. It also affects memory, abstraction, and analysis in those taking it. Other neuropsychiatric side effects includes difficulty in concentration, and there is a global change in cognition with presentations either of delirium or dementia with varied manifestations. Most of these neuropsychiatric manifestations usually quickly resolves once it is dose tapered or discontinued, and the risk factor for such manifestations are found to be higher doses of steroids or prior history of psychiatric disorders, and high incidence is found in the initial 3 months of treatment. We will now dwell on glucocorticoid induced osteoporosis. There is a significant decrease in the bone mineral density within the first 2 to 3 months of initiation of these glucocorticoids. Initially, in the first year, there is nearly, it can go as high as 12% of BMD is lost, and this slowly comes down to, in the subsequent years, to 2 to 3%. The increase in the fracture risk is usually dramatic and early, especially for the vertebral fragility fractures. And then the negative effects on bone is usually dose dependent. Here you can see the vertebral bone collapse due to the corticosteroid use. And usually the negative effects on the bone is usually dose dependent, and all we have to know that there is no dose which is safe when it comes to corticosteroid. There is even the lowest of the dose has been found to have some effect on the bone. And this bone loss is found to be predominant in the trabecular bone, and leading to more of fragility fractures. And this has involvement both due to decreased osteoblast activity and increased osteoclast activity. And there is a contribution pathophysiologically due to decreased calcium absorption in the GIT and increased renal calcium excretion, and also decreased collagen synthesis in the pathophysiology of this. As compared to the fracture risk, there is an increased fracture risk with glucocorticoids, but this decreases on discontinuation of the steroids. But nevertheless, it doesn't return to normal immediately on stopping the drug. And the Frax tool, which we use for the fracture risk, captures this corticosteroid use, but it doesn't give allowance for dose modification. But nevertheless, subsequently there has been an article which gives about adjustment for corticosteroid dose by Canis himself. Other commonly encountered effect on the bone is the osteonecrosis, which is the avascular necrosis. This refers to the cellular death of bone components due to interruption of blood supply, frequently requiring surgical treatment to rebuild the bone. And there has been no consensus on the relative risk with different routes. And identifying this entity of avascular necrosis and having a conservative intervention early on could reduce morbidity associated with aggressive surgical treatments of osteonecrosis. And once suspected, it would be a best idea to safely reduce the dose or discontinue it altogether. The commonly affected joints are the hips and the knees, and the plain radiographs show the bone collapse, but it may not be evident immediately. Only after a few weeks after the onset of symptoms, then we may be able to see it in the plain radiographs. So if you want to capture it early, then the best modality to use is the MRI, where we can capture the bone edema as well as bone destruction. Other predominant effect of glucocorticoids is the risk of infection, and this glucocorticoids affect both innate as well as acquired immunity, increasing the risk of various infections. These observational studies show the increased risk of serious infections, and this risk of infection was found to have a dose-response relationship. With higher the dose, the higher the infection, and concomitant immunosuppressive medication and underlying disorder is also to be taken into account while considering this infection risk. A meta-analysis had gone into this aspect, and they found that the relative risk of the serious infection complications was 1.6, relative risk of 1.6, and for those taking prednisolone doses between 20 to 40, the relative risk of infection was 2.1, but they did not find much increased risk when prednisolone doses were below 10 milligrams. And when they found this combination therapy with immunosuppressive agents was found to increase the infectious complications. As regards the bacterial and fungal infections, the bacterial infections are most common complications of corticosteroid therapy, and any bacterial pathogen could be causative. And invasive fungal infections are commonly observed, especially in chronic corticosteroid therapy. Classical is the Pneumocystis carinii, or recent newly named Pneumocystis cerevisiae pneumonia, especially associated with high-dose glucocorticoid therapy in children or adults with cancer, solid organ transplants, or collagen vascular diseases. Here we see is a classic orbital mucormycosis following long-term steroid therapy. The viral infections of steroid most commonly involve viral complication is the reactivated herpes infections, and H1N1 influenza pandemic showed a trend towards increased mortality in corticosteroid patients of all ages, and the recent recovery trial with COVID-19 had shown the benefit. Usually there has been till now there has been only increase in mortality due to use of steroids, but there is it has been shown in the COVID-19 studies that in a section of people with those oxygen requiring or in those requiring mechanical ventilation, steroids have been found to have a benefit and have a decreased 28-day mortality. And reactivation to active replication of hepatitis B and C virus occurs also is found in glucocorticoid therapy. As regards the ocular side effects, cataracts related to corticosteroids usually develop following prolonged corticosteroids and is usually bilateral, develops gradually and located in the posterior subcapsular location. They have been found to elevate the intraocular pressure by accumulation of the extracellular matrix material in the trabecular meshwork, leading to increased aqueous outflow resistance, and increased risk of glaucoma is found to be there in those receiving even glucocorticoid steroid eye drops. Actually, these steroid eye drops are found to have more risk as compared to systemic administration. Therefore, patients receiving prolonged glucocorticoid high dose therapy should have periodic ophthalmological monitoring. As regards the gastrointestinal side effects, these increase the risk of gastritis, ulcer disease, gastrointestinal bleeding, and glucocorticoids per se, they have only a marginal increase over the GI events, while concurrent use of NSAIDs, there is a synergistic increase in the rise of GI events. There is an increased risk of cardiovascular disease, especially in doses of more than 7.5 milligrams of prednisolone. And this has been predominantly with ischemic heart disease and heart failure in large studies. But the association with smaller doses less than 7.5 milligrams per day has been found to, the association is unclear. So in summary, we saw that corticosteroids have been a double-edged sword. It has been both treatment of choice for various inflammatory, allergic, immunological, dermatological disorders, but also, on the other hand, has been associated with myriad side effects encountered in supraphysiological or inappropriate concentrations. So, I would like to conclude by saying that it's a savior when used judiciously, and a Satan guised as a serpent when used indiscriminately without evidence. Thank you.
Thank you, Dr. Satish, for that excellent talk. We'll reserve questions at the end of since there's one more talk. The final talk in this session is about COVID and its consequences. There cannot be a session complete without discussion on COVID. And this is although we know that diabetes is so common after COVID, there is lot of discussion on other autoimmune diseases, especially thyroid diseases after COVID. So to throw more light on that will be Dr. D.B. Nayak, MD DM Endocrinology. He is additional professor and head of the Department Endocrinology, Jipmar Puducherry. His research area of interests are steroids, cancer-induced diabetes, osteoporosis, and endocrine disorders, and he's got 50 publications in reputed journals to his credit. Over to Dr. Nayak.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank the Madurai Tender team for giving me this opportunity. As we know, everybody has know about the acute complication of COVID and their outcome. Today, we are here to discuss about the post-COVID related to thyroid dysfunction. This is the agenda of presentation. First of all, I will be discussing the post-COVID syndrome and what is its mechanism, acute COVID and what is its impact on thyroid dysfunctions. Then subsequently, I will discuss the post-COVID and the impact in its mechanism on thyroid autoimmunity and thyroid dysfunctions. And as we know that everybody has received COVID vaccine and what is its impacts on the thyroid dysfunction. If you look at the current scenario of COVID, as of now, nearly 537 million people are being infected by the COVID. And total death rate till date is 6.31 million. But if you look at even after recovery, these patients develop many kind of symptoms, and this is categorized as a post-COVID syndrome. Can be seen up to a tune of 10 to 15% in patient with COVID. And this post-COVID syndrome was defined by the WHO saying that if the symptoms, the post-COVID symptoms which are persist more than 12 weeks after recovery is defined as a post-COVID symptom. If you look at the symptoms which are seen in post-COVID, are largely maybe like fatigue and weakness, but it has symptoms can be of any system. If you look at neurological symptom, psychiatric symptom like cognitive impairment, decreased sleep, headache, anxiety, depression, cardiovascular symptom like chest pain, palpitation, respiratory breathlessness, persistent cough, and GI symptoms like altered bowel habit and musculoskeletal symptoms these are the very most common type of symptoms has been described with post-COVID. This is the possible mechanism of post-COVID syndromes. This has been there are several studies look at the persistent of virus, persistent contribute to the post-COVID symptoms. And even if you patient recovery from the infection, there will be still persistent of inflammation or that also can contribute to the post-COVID symptoms, and persistent of tissue and organ damage, and that will also trigger the autoimmunity and immunodysregulation. and even in the change in the central nervous system, cardiovascular system can contribute. Moreover, there is dysregulation of pituitary adrenal axis, pituitary thyroid axis, even pituitary gonadal axis, which can contribute to the post-COVID symptom. I'll be next covering the thyroid dysfunction in acute COVID. This is the mechanism how the SARS-CoV virus entered through the thyroid gland, because it has a AC receptor, so it can directly attack the thyroid glands. Similarly, after it is entering to the airway, it can produce excessive cytokine because of inflammation and produce a cytokine storm, which can impact the hypothalamic pituitary axis, or it can directly impact the thyroid. Even through the mediated through the autoimmune process, which can produce the chemokines, which can impact the thyroid function. So there are various thyroid functions which are described in the COVID patient with acute infection. Most common is the sick euthyroid syndrome, also known as low T3 syndrome. And as I told, the inflammatory markers can involve the HPT axis, which can mimic like a secondary hypothyroidism, which is also known as functional hypothyroidism. And there are several reports of clinical picture mimicking like thyrotoxicosis, which is predominantly because of thyrotoxicosis. Looking at this data which is available in Indian context, this is the study which has done from the India. So you can see the around 230% was studied in this study, and you can see around 24% of patient has sick euthyroid syndrome, and low TSH was found in around 4%, and high TSH was found in the 7%. So this kind of pattern of thyroid dysfunction has been described in various studies, and in many studies also they have looked at the prognostic factor. Similar to this study, in this study they have low T3 is being considered as the independent predictor of severity and outcome in COVID. This is another study from the PGI Chandigarh, where they have looked for the thyroid dysfunction in a COVID patient. They have included 84 patients. If you can look at the previous studies, the low T3 or sick euthyroid syndrome proportion is very less. But in this study, they found about 74% of the patient had low T3 or sick euthyroid syndrome, and more so in the patient with severe illness. And they have described a very atypical pattern. Normally, thyroiditis, we consider it as a subacute thyroiditis or decruven thyroiditis, which is typically associated with low TSH and high FT4 and high T3. But that, particularly in case of COVID disease, this atypical thyroiditis is typically described as the T4 above the upper normal range with normal or low TSH, and it was more found in severe patients as compared to mild cases. Not necessarily that there are, there may be only abnormality in the single parameter of thyroid function, like isolated T4, isolated low T, isolated T3, and isolated TSH abnormality also described in the literature. This is another study from the Italy where I looked at the 287 patients, but this study is totally different from the what described in the other literature. They found about 20% of patients have a feature of thyrotoxicosis, because in case of thyroiditis with COVID infection, initially there was no symptom or the levels are not very high. But in this particular study, they reported out of significant number of patients have biochemical feature of overt thyrotoxicosis characterized by low TSH, high T4 and high T3. The high incidence of thyrotoxicosis in these cases could be because of destrotic thyroiditis, and it is primarily due to the systemic immunoactivation. So from this all three studies, it is clear that in patient with COVID, particularly in acute phase, you can have a abnormality in sick euthyroid syndrome, thyroiditis, secondary hypothyroidism due to functional hypothyroidism. So whether these findings in the acute COVID is replicated in post-COVID, or their findings are totally different. How the SARS-CoV produce autoimmunity? Because once the inflammatory process is subsides, most of the time the functional abnormality, non-thyroid illness will be not very common in post-COVID. So it is largely can be because of thyroid autoimmunity. This is the mechanism. Once the virus is entered into the thyroid in body, they usually taken over by the antigen presenting cell. They act on the subsequently stimulate the T helper cell. The T helper cell subsequently stimulate the B cell, and they are the cell which is responsible for the producing autoimmunity. If you look at the pattern of thyroid involvement, like you see thyroiditis or Hashimoto's thyroiditis or Graves' disease, With regard to autoimmunity kind of thyroid disease, we define as a Hashimoto's thyroiditis, Graves' disease, and painless thyroiditis come into the category of autoimmune disease. From this slide, you can be clear that like Graves' disease is always associated with pre-existing autoimmunity, or it can be due to de novo induction of autoimmunity in case of post-COVID. But thyroiditis, particularly subacute variant, is usually not related to autoimmunity, but paleness or postpartum variety can be related to pre-existing autoimmunity. Hypothyroidism is a Hashimoto's thyroiditis can be a autoimmune disorder, and it is can be due to de novo induction of autoimmunity by COVID. This is the study which is looked at the thyroid function during COVID and after COVID. They try to compare the thyroid function with the thyroid function available in the previous year in the non-COVID era. And when they compare, they found that if you compare with the during and before the non-COVID timing, the TSH and FT4 was found to be significantly lower during the acute infection. And they followed this patient for a period of 3 months. And during their follow-up, they found that around 2% has thyroiditis. So this is not necessarily common with COVID. Can occur with any kind of COVID, any kind of viral infection that they can develop a kind of thyroiditis known as subacute thyroiditis or recurrent thyroiditis. This is another study from India, which has done from the West Bengal. It is a retrospective prospective study. Retrospective because they have taken the thyroid function done during the time of acute COVID, and they have prospectively followed the 160 patients. Those are come for follow-up. In this study, they found about 11 patients, that is constitute about 7% of patients have subacute thyroiditis. And these patients they have followed for 6 months. And the typical picture of subacute thyroiditis in their studies, mean age was 44. And all kind of thyroid patient with severe, mild, moderate, asymptomatic patient can have a subacute thyroiditis. And if you look at the outcome of this study, significant number of patients with subacute thyroid usually resolve by itself. So out of 11 patients, 9 patients become euthyroid and 1 patient have subclinical hypothyroidism. They have categorized into 2 groups, that is painless thyroiditis and painful thyroiditis. Painless thyroiditis, if you compare between the painless and painful thyroiditis, you can see that the age of onset are younger and the presentation from the recovery was much shorter, and inflammatory markers are higher in patients of painless thyroiditis. But painless thyroiditis is something it's very, very difficult to pick up because largely we only evaluate these patients when they are present with the painful thyroiditis. And at the outcome, I have already told that most of the patients become euthyroid. So in another study where the thyroid dysfunction and relation to immunoprofile were studied, in this study they have looked the thyroid function in a patient with abnormal thyroid function was found in 25 patients. They have measured the autoantibody in this patient, about 188 patients. At the acute infection, they found that around 30% of the patients have TPO and antibody positive. But presence of TPO antibody or anti-TG antibody does not define that they are likely to develop dysfunction. Even these patients in the acute COVID have this autoantibody, they are not having any significant thyroid dysfunction. And they have followed the patient, around 25% they have followed and re-evaluated after recovery. And they have found that about 2 patients persistently have low TSH, elevated FT4 and FT3 and TSH receptor antibody, which is suggestive of Graves' disease. And 2 patients have autoimmune thyroiditis and that are favoring Hashimoto's thyroiditis. From this study, it is clear that they not necessarily subacute thyroiditis. Patient recovering from COVID can have chance of developing Graves' disease and Hashimoto's thyroiditis. This is another study also looking at the outcome of the study done at baseline at 3 months. About 1 or 2 patients were having normal thyroid function. When they follow up these patients, you can see that significant number of the patients become euthyroid. Only 1-2 patients have abnormal thyroid. So there is a variable report. Some studies show there is abnormality in the thyroid function, but some studies show there is no significant abnormality in the thyroid function during follow-up. But in this particular study, they looked at the antibody status and trap antibody, that the TSH receptor antibody, which was measured at baseline and at the recovery. And they typically found that there is an increase in the TPO level during the time of recovery in patient with COVID. So, but this is not translate into the positivity rate because they have taken cutoff of more than 100. And they have also measured the trap antibody, that is for TSH receptor antibody. There was no significant difference in the TSH receptor antibody at the baseline and at recovery. But there are factors which can associate with the high titer of TPO antibody if there is severity of illness, high titer of TPO at baseline, and high CRH. And they have looked at the patient, those are baseline TPO positive and baseline TPO negative. Particularly in the negative, there is mild increase in the titer of TPO at the time of recovery, and 4 patients become positive. But those patients having TPO positive, they remain positive. Only 1 patient have TPO negative, but titer is very high because positive anti-TPO titer is defined as 100. So another study from India, we are looked at the, because in the as we are looking at whether the autoimmunity, post-COVID autoimmunity increase the risk of thyroid problem in post-COVID or not. This is another study from India, from All India Institute of Medical Science. They have taken the GDM patient, those are GDM, post-GDM, those are following with them, and they looked at the autoantibody status at various time point following the recovery. They have categorized the mild infection into those of seropositive and non-symptom of the COVID-19 infection. And in the study, they have shown that categorized into the infected group and non-infected group. But if you look at the proportion patient of TPO positive, there was no significant difference in the autoantibody positive in the mild patient. So in the study, they have concluded that TPO positive between infective and non-infective patient was not significantly different. Even the progression to thyroid dysfunction also was not significant. And Graves' disease, with regard to Graves' disease, there are only case reports available in the literature with regard to the occurrence of Graves' disease and also occurrence of recurrent Graves' disease in patients with post-COVID. With regard to vaccine, as you know that we are all received a vaccine, the post-COVID vaccine can also induce autoimmunity. It's also known as ASIA syndrome, autoimmune inflammatory syndrome in response to adjuvant. So far from India, there is only 1 case reported with regard to this, and most of the literature are from the Western countries. This is the 47-year female, which was presented 2 weeks after first dose of vaccination. This is because of AstraZeneca vaccine. But this kind of thyroid autoimmunity only seen in patients with mRNA-based vaccine and viral vector vaccine. This mechanism behind can be because of molecular mimicry, epitope spreading, polyclonal activation, or bystander activation. There are several reports of thyroid dysfunction in post-COVID, like Graves' disease, Hashimoto's thyroiditis. As these reports are not from the India, I have not shown in the literature. To summarize, I can say that the association between the acute SARS-CoV infection and thyroid dysfunction is very, very definite in the acute stage. As we have seen the literature that SARS-CoV-2 do induce the thyroid autoimmunity, and post-COVID SARS virus could induce the subacute thyroiditis, but subacute thyroiditis is not an autoimmune disorder unless otherwise it's a painless thyroiditis. It can induce the autoimmune other disease like Hashimoto's thyroiditis and Graves' disease. But if you look at the whole literature which is available at present, the proportion of patients developing this kind of autoimmune thyroid disease are very, very minimal. So we need further research in this area or a long-term study to define that the post-COVID leading into more thyroid disorder. Finally, to approach to a patient with post-COVID thyroid dysfunction, if you have a patient having been referred with a thyroid function abnormality, you may need to look at whether the patient having any post-COVID symptom or not. Particularly in case of acute thyroiditis, patient will have acute neck pain. If his acute neck pain is there, probably patient have a painful subacute thyroiditis. But if you have a thyroid function like that, even without pain, patient probably have a painless subacute thyroiditis. But however, you cannot rule out Graves' disease from the painless subacute thyroiditis or painful thyroiditis. For that purpose, you need to know this investigation. Thyroid ultrasound can help you and guide you. Particularly in case of subacute thyroiditis, these inflammatory markers can be elevated. So that can guide you in saying whether patient have a subacute thyroiditis or not. And if you have availability of thyroid scan, it can clearly tell you whether there is increased uptake or decreased uptake. Particularly if there is high uptake, then it's more suggestive of Graves' disease. Graves' disease, and if you have low uptake, it's more suggestive of subacute thyroiditis. If there is no pain, it can be easily managed with beta blocker. If there is pain, then you may need to consider starting with NSAID or steroids. And if you want to further prove, then trap antibody, the TSH receptor body can guide you whether you are dealing with a Graves' disease or not. And if you patient have a specific hypothyroidic symptoms, you should look for TSH. If TSH is more than, then there is an indication to define them as a patient having overt hypothyroidism. And you want to further establish the etiology, whether it is because of Hashimoto's thyroiditis, then ATPO or ultrasound, ATPO positivity can tell you whether it is Hashimoto's thyroiditis. And thyroxine are the definite treatment for this hypothyroidism. Thank you for your questions here.
Thank you, doctor, for your nice presentation. Of course, the word COVID, it paralyzed the entire world for the past 2 years. The COVID infection, of course, it produces autoantibodies, which can affect every organ in our body, and of course, thyroid is not an exception. You presented very well.